Well, Karin, I do have the top of the hour, and I want to be respectful of everybody's time. So I will go ahead and just kick us off here as people are trickling in. So hello, everyone, and good morning to the second installment in the Community Paramedicine webinar on the highlighting the framework. Now, this meeting is being recorded and will be posted to the website following the conclusion of today's event. We do love feedback, so please feel free to unmute, use the chat box, and join in on the conversation. We do ask if you are not actively speaking, to keep yourself on mute because it does cut down on feedback. Now, the National Rural Health Resource Center is a nonprofit organization dedicated to sustaining and improving healthcare in rural communities. The center is the nation's leading technical assistance and knowledge center in rural health. The center has served rural healthcare organizations and partnered with the FORHP for nearly 25 years and collaborated with Delta Regional Authority for nearly 15 years to assist rural providers and communities with rural health needs. The center is committed to diversity, equity, inclusion, and anti-racism, and building a culture where difference is valued. You can learn more about what the center is doing in DEI on our website, which is linked below. With the support of the Delta Regional Authority and the Health Resources Services Administration's Federal Office of Rural Health Policy, the center administers the Delta Region Community Health Systems Development Program and manages the provision of services to selected healthcare organizations and communities over a multi-year program period to make in-depth health system enhancements to position healthcare organizations and communities in population health. Now I will turn things over to Karin Lund. She is a senior program specialist that has worked with the DRCHSD program for nearly 3.5 years with the community care coordination team. She will serve as the lead for community paramedicine technical assistance moving forward. Karin, take it over.
Thanks, Caleb. Before I jump right into community paramedicine, I want to again share the DRCHSD program purpose and goals for our individuals joining us on a webinar for the first time. This program has been assisting healthcare organizations and communities since 2017 to develop a sustained local system of care. Services are provided through technical assistance, which includes various assessments and consultations, action planning, and coaching implementation of best practices that work to improve care coordination, quality of care and patient experience, awareness of local services, reduce bypass of local services, enhance partnerships and collaboration, increasing the long-term viability of the organizations, and as Caleb mentioned, sustaining a local system of care to prepare for population health. All of these goals shown tie directly into our newest technical assistance area, community paramedicine, which will further enhance care coordination in the communities that we serve. Today, we want to build off the energy and interest from last week's webinar and dig into greater detail on our community paramedicine framework components with the assistance of our panelists. We will also highlight the application process for this technical assistance, talk about next steps, and take any questions before we close. As Caleb mentioned, we encourage participants to use the chat box for your questions throughout our time today. We are welcoming back our panelists from last week's webinar to hear more about how the core components of our framework are important for implementing and sustaining community paramedicine programs. Thank you again, Paul Miller, Division Chief of EMS, Crawfordsville, Indiana Community Paramedicine Program, and Richard Bell, Operations Director with Acadian Health out of Louisiana. We will also be hearing from Melissa Meller, COO for the National Rural Health Resource Center. She directs and acts as a subject matter expert for our program's community work. Last week, we talked about how our triple aim, Healthcare 3.0 and EMS 3.0, align priorities to support the transformation of our nation's healthcare, to add value and ensure that the right care is delivered at the right place and at the right time. We also heard how community paramedicine programs provide enhanced care coordination, case management, and healthcare delivery of non-emergent services that fill healthcare gaps in communities without duplicating healthcare services. Today, we want to dig deeper into the framework components of this program that will help us develop and sustain a community paramedicine program. Now I will turn it over to Alyssa to speak about our framework.
Thank you, Karen. Based on previously identified needs from EMS assessments, community care coordination initiatives across the Delta, literature and resource review, the center developed a community paramedicine framework. This slide represents the core framework of the center's community paramedicine technical assistance program. Each of these components are critical to successful models. So the technical assistance approach incorporates center-known processes, tools, resources, and working with key center and consultant subject matter experts. This program is extremely customizable and will meet each healthcare organization and community where they're at. We, along with our partners, will guide healthcare organizations, local providers, EMS, community partners, and organizations through engagement, planning, preparing for and implementing and sustaining a community paramedicine model. I'll briefly walk through each of these core framework areas over the next slides, and we'll engage each of our panelists to provide comments within each area to discuss how they addressed and planned for each component. The feasibility assessment is an in-depth analysis to understand the beginning of a sustainable program. It's the foundation that will feed all the core components. It will inform the current strengths, assets, and gaps or opportunities for many of the components. The feasibility assessment will begin upon acceptance of a healthcare organization and its community into the community paramedicine program. Through this discovery, any federal, state, and/or regional funding, Medicare, Medicaid, and private payer reimbursement opportunities will be identified. If there are current funding streams, they will often dictate the target population, community paramedic scope of practice, and billing codes, just to name a few things that we're looking for in this assessment. So the result of the assessment will inform all the components, but most important, inform the business and sustainability plan as well. In addition to looking at the funding streams, the feasibility assessment will also take a close look at the community's population health needs. This will be completed by pulling existing data from community health status reports, local EMS records, needs assessments, and really any other publicly available databases, as well as current data from healthcare organizations' electronic health record. The intent of this first step is to really understand the current environment and ongoing opportunity for successful community paramedic work. So Paul and Richard, when you think about the feasibility, what was that first step or more important step to determine if a community paramedic program was feasible in your community? I know we spoke a little bit about this last week, but what were some of those first steps that you took? Richard, we'll start with you.
Sure. So the first steps we took, we as an EMS agency, we knew that there were huge gaps in the system because we were being called to go in and try to address the needs of the population or the community to try and help fill that gap for them. So we knew that there was a great need in all the communities that we serve to be able to help people navigate systems and also to be able to provide them with the care that they need in the appropriate setting and keep those people out of the emergency department. But I can tell you that the biggest hurdle that we had to overcome was building those payment models, right? We all want to do the best thing that we can for the communities that we serve, but at the end of the day, somebody has to pay the bills. So it was trying to develop those partnerships with ACOs and payers to basically paint the picture for them to say that, look, we're a resource that's already there and we can fill this gap and help you to manage these high utilizer populations or populations of patients that, you know, they're at greater risk for readmission and whatnot because they just don't have the ability to take care of themselves. So the payers, they know that these populations exist too, but it's a matter of how do you get a reimbursement model in place and a negotiated reimbursement in place to be able to move forward to where you have that sustainable reimbursement model. You know, a lot of the early programs, the early community paramedicine programs, they were established by using grants, and grants are great, but at the end of that grant, you better have a sustainable reimbursement model in place, or your program is just going to go away, right? So I can say that, you know, in our experience, or in my experience, that was the biggest hurdle to come over, or to be able to get over, was developing those relationships with the payers and with the ACOs, and building that reimbursement framework.
Thank you, Richard. Paul, you know, kind of building off of that, or maybe another first step that you and your organizations took to determine if it was going to be a feasible community paramedicine was a feasible model in your community.
Really open up that dialogue. So initially, we were wanting to focus on a very siloed problem that was happening to us, and we were wanting to utilize the health system to help us fix it. By engaging with them, we started working and sharing experiences where we're both experiencing gaps. And then ultimately, when we're talking about sustaining it outside of grants, we need to figure out how we can better fit into their business model. And we both sharing those experiences and wins. And at the time, our issue was falls in the home. The hospital's issues were 30-day readmissions. So we started looking at that, pulling in the local and state health departments, looking at community needs assessment, and seeing how we can construct a project that would benefit both entities, public and private, kind of in a shared values approach, and then work on that sustainability plan, whether it's a fee for service or a shared savings or whatever it may look like in different communities.
Great, thank you, Paul.
And we started, and Paul probably went through this too, is, you know, we would like to get to the point to where we have a capitated reimbursement model in place, and then move to a shared savings. But in order to get there, you have to have the data, right?
Correct.
So primarily our programs are fee for service right now, but we're moving towards those capitated arrangements. And then the next step is going to be the shared savings model.
Great, thank you. The center developed a tool called the Care Coordination Canvas. It assists healthcare organizations and communities in developing and refining their care coordination program. The center, healthcare organizations, and key partners will utilize the Canvas in its community paramedicine planning. This is where the collaborative, that means your organization, partners, providers, identifies an intended population, or what the Canvas calls a target population. This is critically important. Our panelists spoke to this in last week, that it must be focused, small, you know, to perform, learn those right steps for engagement and buy-in with all your partners. And so therefore, the Canvas steps will focus the collaboratives program to improve the care, health, and reduce costs for a specific group of people. The community paramedic care coordination model will have a clearly defined goal, intended outcome, and must be measurable. Within the care coordination model planning and development, the collaborative will identify what assessment or triage tools are needed. Where does the care plan, what does the care plan need? Who's the care team? How does the community paramedic and care team provide care and coordinate care based on to meet the intended outcome of that was defined in identifying that target population? Paul, what data sources, you mentioned this a little bit in your answer, you know, did your group use to identify the target population? You talked about the hospital's readmission rates and the folks that were triggering that, and community health needs assessments. And so maybe building off of that, how did you determine the goal or the outcome? You know, I mean, how did you talked about communication with the hospital, things like that, but how did you come to a mutually agreed agreement on that goal or outcome of that?
So very early on, we set up a board for transparency and making sure we were benefiting all of our key partners. And that consisted of our local health department, their medical director and health administrator. And we looked at their data, their community needs assessment. From the hospital, we had a group.
I think we have lost Paul.
Okay, I was hoping it wasn't my internet connection. Thanks, Karen. All right, so we'll circle back with Paul to finish that thought, because that was a great stream up. Then I'll Richard, are you with us? And could
I am, yeah. Yeah,
Yeah.
I was wondering the same thing. I was wondering if it was me too.
Right.
Uh,
So when you talk about your target population, how, maybe how did you determine the goal or outcome too, but how did,
mm.
kind of taking that next step further, how did you come to agreement on the model or the care coordination around that population too, to just talk a little bit more about that?
Yeah, we met with some of the community partners that we had. We looked at, we met with hospital systems. We met with, larger physician groups that were under a capitated arrangement to manage a specific population, and just talk to them about where the gaps in their system existed. Because one of the things that we wanted to make sure right out of the gate is we wanted to make it very clear to everybody that we were working with is that we're not here to compete with any other industry. We're here to identify what gaps exist in their systems, and then what can we do to help them address those gaps and fill those gaps. One of the things or some of the things that was most important to the partners that we were talking about was 30-day readmission reduction, obviously for hospital systems. When it came to ACOs, it was reducing costs by getting those people, those high utilizers of emergency services, to go into the field and find out what was the root cause of them using the emergency services so frequently. And what we found was through the social determinants of health assessments, a lot of the problems, the root causes that we were able to identify, really didn't have anything to do with clinical care. It had to do with social determinants, right? Access to transportation, access to funds to be able to fill their prescriptions and whatnot. So it was all about, in every community really is different too. And that's one of the things that's a little bit different about our program, as compared to other programs, is my organization covers a very large geographic region, multiple states. So all of our programs are different because the community needs are different wherever you go. There's resources in some communities that aren't available in other communities, right? So, there's no cookie cutter approach. It's a matter of sitting down with the other stakeholders in those communities and talking about where the gaps exist, and then figuring out how we can step in and help them to fill those gaps. But, it was primarily readmission reduction, and it was also the focused on the high utilizer groups.
Thank you. Paul, I think you're back. I apologize.
I apologize for that. I've had to shuffle offices today, and the connectivity where I'm at is a little rough, so I apologize.
Totally understand. Why don't you go ahead and finish your thought? You were talking about kind of how you narrowed in on that target population with those key partners and how you did that. Yeah,
so it's really just like Richard said, it's looking at the low-hanging fruit and seeing where you can be successful. While we wanted to focus just on reducing our falls and making our run volume go down a little bit lower, the hospital was really looking at getting incentivized payments. They started to pioneer ACO. So they needed to help with population health regarding the 30-day heart failure readmissions. So we saw that, one way that they're readmitted is an all-cause readmission. Let's get us in the home, set things up, and be successful on trying to achieve those goals. And then there's a win-win for everybody in that. And then our kind of neutral, kind of third-party agency is always the local health department. To kind of make sure, I don't have a background in healthcare administration, so it would be easy to take care or take advantage of any fire department or maybe even private EMS, to making sure we're only helping a health system be successful in one area, and not everyone in the community is getting goals in healthcare met.
Okay, before we move on to the next component, I was wondering if you could briefly talk about how you guys identified your community paramedicine model. So you have your population, whether it be falls risk, readmits, there's different disease states, things that you're looking at and all of that. How did you come to agreement and look for successful models to recreate or to try in your community or work through? Like what was the best practice, I guess? How did you learn about that or learn more in that area.
What we did was, I went back and reached out to the people that I heard speak and read articles, published articles about their experiences. You look back at the pioneers in this, right? You look back at Eagle County, Colorado, and the program that they had out there, and Wake County EMS over in North Carolina, and Dan Swayze and his group up in Pennsylvania. So you had those early pioneers of this concept. So it was about reaching out to them and learning from their mistakes and learning from their experiences and taking advantage of that. So, I just learned as much as I could about the concept from the people that had been doing this already. And then it was a matter of seeing how their program could fit into the situations that we were trying to address for the partners that we had on a local level.
Great. Thanks, Richard.
I'd agree with that. We did the same thing. Eagle County, Hennepin College, Swayze in Pennsylvania. They all had different nuances to their programs and different abilities to deliver paramedic services. So some of them were more social based than they were clinical. And we attended those conferences with our internal hospital leadership team. So making sure we had an internal voice, always kind of pushing that momentum and excitement that we were bringing back from meeting with those people internally. And then based on our resources, constructing our own model and what we thought would be beneficial.
Thank you both. The workforce component really takes a holistic approach. It begins with the leadership involvement, support, and understanding of, and the need for intent of the community paramedicine program. This includes not only the leadership at the healthcare organization leading this effort, but the local EMS, other providers, and key leaders within the community. So the center will work with selected organizations and important key stakeholders to facilitate an event or workshop to set the stage, to gather input from all stakeholders, obtain agreement among those key leaders that will have direction and dedication for the community paramedicine project. So other areas that will be discussed and planned for are, we really need to understand and have a clear understanding of what those federal, state, regional licensure and scope of practice requirements, if there are, for community paramedics and its programs. What was discovered in the feasibility assessment will be referenced and utilized to develop the community paramedic role and care coordination model development. And there must be medical oversight of the program, so defining what's required, who is it, where does it reside, will it all be important roles, will all be important roles and responsibilities to answers. And we can't forget, the administrative support that is needed for a successful model. Things like who and how we will coordinate referrals into the program, across the providers, outcomes tracking and reporting are all important considerations to account for. If a community paramedic is not currently hired or a person in mind, there's technical assistance available to outline the steps to creating a job description, posting it, interviews, and this assistance will really be focused on around that scope, experience, licensing requirements, steps to recruit, hire, and retain qualified community paramedics. We touched upon the community paramedic workforce in last week's webinar. I'd like for each of you to speak about the administrative support you have in place for this work. Please share, how that person or people are identified. Once you have your defined target population, how are they triggered to be outreach to? How are they identified and referred into your program? Who does this? Right, Richard, why don't we start with you on that?
Sure. We one of the benefits I think that I have, and I'm thankful for, is because we're a rather large organization. We already have that infrastructure in my organization. So we have a billing department, we have data analysis, we have a business intelligence department. So I have resources to these experts in their field in all of these different disciplines that I could go to and ask them, okay, look, this is what we're trying to do, and these are the things that I need from you. And they were able to come back to me and say, okay, you told us what your needs were, and this is how we're going to be able to deliver, right? So I was very lucky in that respect that I had access to people that were already inside of our organization that could be redirected to focus on the whole concept of community paramedicine when it comes to reimbursement, referrals, all that good stuff. But when it comes to identifying the patients, we just talk about, what does success look like, with the partner? And what specific group of patients are we talking about? Are we talking about just generally, high utilizers, and it could be all causes, it could be a combination of multiple disease processes, or do we want to focus specifically on a CHF 30-day readmission reduction program? So again, it's about talking to your partners and finding out where their gaps are and where their pain points are, and then focusing on that. But what we do is we always rely on our partners to share their data with us so they can refer their patients or their members, if we're talking about a payer, to us, because they're looking for specific criteria to be referred or enrolled into the program. And then it's just a matter of going through their data with them to agree on, okay, well, these are the parameters that we're going to use as a trigger for referral into the program. And then just as importantly, what does success look like? And also, how do you remove somebody from the program? Because not every patient is gonna buy into this program. They may say initially that they're open to it, but then when we go and we meet with a person for the first time, and we've experienced this where they say, you know what, we appreciate y'all coming out. This is all great and everything, but I'm going to tell you, as soon as you walk out the door, I'm throwing all this in the garbage, and I'm going to keep doing what I've been doing for my whole life. Well, it's not fair for us to continue to try to see that person and get reimbursed for that, knowing that we're not going to be able to move the needle on that specific person or group of people, right? And we don't want those people in the program because they're going to skew the data. They're going to negatively impact the outcomes of our program in a general sense. So it's a matter of identifying who's going to be referred into the program, but also how do you identify those people that you want to remove from the program and come to an agreement on how that happens too.
Richard. Paul?
Ours is,
I think
might
you
be
have a little
slightly,
different situation, I think.
ours might be slightly different. We have multiple different initiatives, so 6 different initiatives, and each one of those projects has different referral pathways to develop that kind of care coordination and everything. So primarily we receive referrals from our ACO nurses. They're the first step in making sure we're not duplicating services. Then we'll go out in the home, see if they qualify for a higher level of care, could be hospice, could be home health, and then we may refer out. So that would be one way we're making sure that we're kind of cherry picking and getting the patients that are going to be compliant. But oftentimes when we received referrals from home health that were dealing with non-compliant patients in their space, we were able to be successful with them being in our project. So that's one referral resource that we're able to track and make sure we're achieving our goals. But when they come through probation, DCS, it may look different in how we're doing that. We have 5 behavioral health facilities we work with, and they're more partners.
Okay. Great. Thank you. So based upon the community paramedicine care coordination model and its attended outcomes and communication and technology assessments will be completed to support the model. And so we kind of think about communication in 2 ways. The first area is really how to communicate or share this opportunity for care with your partners, with your community, and so forth. So it's going to be a new service line, new area. What does this communication look like for the referrals into the program? So with the patient or person receiving care, who outreaches to them, who shares this opportunity with them? How do you develop the care plan with and share with the providers? So it's the actual talking with, kind of discussing, documenting, and sharing information. And the second aspect to communication is the actual technology to support the care delivery, communication, and documentation of the work y'all doing. So through these assessments, recommendations will be provided to build off existing communication and technology platforms, equipment and supplies that's already exist. Opportunities or gaps will be identified that will be able to strengthen those communications and delivery areas. So possible areas that we've thought about, and this again is not all inclusive, are broadband access, interoperability between electronic health records of those participating partners and providers, remote patient monitoring, telehealth, and so forth. And so the Delta program, this grant is really unique in the way that we have funds available to support this, particularly around telehealth equipment, supplies, interoperative interfaces between things, also including buying and outfitting a community paramedicine vehicle. So it's really cool opportunities around this. So a question to our panelists, what particular part of developing the communications and technology aspects of your program were most important? And you kind of talked about this in some of our other areas. As you can tell, none of these components are mutually exclusive of the other. They're all important, but thinking about that communication and technology, maybe more on the technology side, what aspects are most important? Paul, let's start with you.
So I think in every rural community, access to broadband is pretty important and probably on every governor's agenda. Connectivity for our patients. This past few years since COVID has taken place, we saw an opportunity to enhance care through that. It's always offered some aspect of health. So we do remote patient monitoring. We have Bluetooth, blood pressure cuffs, scales, pulse oximetry that will come to us. We can see it real and live time. That helps us monitor our patients. We get alerts on weight. We do that with our chronic disease patients and our high-risk OB patients. And then some of that information we use to enter into Epic. So our care coordinators, case managers, specialists, and primary care are all able to see that. So if the patient does not have access to Wi-Fi, broadband, any kind of connectivity, we have modems. And then when we walk into the home, it picks up on our system, and then we can take care of it that way. All their data is stored for, I believe, 7 days. And that's typically about the longest we see gaps in visits. So then we just pick up on that data and we're able to see trending up and down and how they're working to achieve their healthcare goals. So that's how we use telehealth. It's really important in our primary care offices. It helps increase RVUs. So if we're looking at doing any kind of remote patient monitoring, transitional care, chronic care management, to get those incentivized payments, these are pathways we need to work through collaboratively to get more support.
Yeah, like Chief Miller said, that the broadband connectivity in rural communities, that's key. I mean, that's something that we struggle with on a day-to-day basis. Even our ground ambulance division deals with that on a day-to-day basis, just being able to have connectivity to make phone calls, much less using remote patient monitoring technology and telehealth technology. But we're not currently using any remote patient monitoring devices in our programs. We just don't have any partners that have expressed an interest in incorporating that into the programs as of yet. We are monitoring what's available out there in the remote patient monitoring space. I definitely see the benefits of using that, but it's a matter of what our partners are willing to utilize also. When it comes to getting our documentation to the providers and back to the health plans, that's key, right? So we use an electronic healthcare record. Our EHR system is something that was designed specifically for community paramedicine programs. It's not a single event driven record like a typical EMS record would be. It's an actual, longitudinal historical health record for each one of those patients. We don't have integrations with Epic or any other big health information exchange or system right now. So we found that the best way for us to meet the needs of multiple partners is just to have the ability for us to, at the end of a visit with a patient, we just simply select out of a drop down on who we want that record sent to via email. And then it's sent to that specific email address as a PDF document. So they can then upload it into any system that they're using, right? But we do have some partners right now that we've been doing business with for quite some time, and we put them in touch with our EHR vendor. So we're working on an integration into specific systems that our partners are using right now. But getting our documentation to the providers, that's key. They have to have that information.
We kind of talked about two interfaces with both of your examples. Paul, you talked about your team has access to Epic, and I'm assuming the health systems have the Epic EHR system on that. So they provided access or login credentials for you guys to document and do that directly, correct? Is that how that works?
Yeah, that's correct. We go through all the same training of all of our providers. We have to meet regular training standards and that stuff. We do utilize ImageTrend as well, which has not been, so they offer integrations into multiple EMRs, whether it's Cerner, McKesson, Epic, but with all the issues with protected health information right now, it's very difficult to get IT to do that integration and open that up. They want very limited access to their EMR. So we have not seen success with utilizing that here locally. We've seen a lot of health systems in Indiana be attacked and ransomed and stuff like that, to where this was an easier process for us.
Okay, great. And Richard, okay, we'll go on to the next one. I had a follow-up question, but I'll come back to that to make sure we have time for it, Karen. So we can go on to the business and sustainability plan, because I know a topic area that comes to my mind, talking about when you talked about protected health information, is the release of information to coordinate care amongst and to share this information too. And if we have time, I want to come back to talk a little bit more how you guys worked through probably a multi-organizational release of information between the health systems and your programs as well too. But we'll come back to that in a minute if we have time. As organizations, that have worked, excuse me, I went too far in my notes. Throughout the planning and development of the model, the center team and our consultants will incorporate the importance of each component area and its impact upon ongoing sustainability of the community paramedicine program. By thinking about this at each step will help ensure continued engagement and support from all community stakeholders, maximize reimbursement from those current payers, and very important, using the program outcomes, efficiencies made, and cost savings, and being able to quantify it to entice funding and reimbursements from new sources and payers. You both have talked a little bit of how important that is, being able to use this data, this information to entice payment. So thinking about that, what is the one win or one outcome that you have found to be the most beneficial or important for those discussions with your payers for this ongoing sustainability of your program? Richard, why don't we start with you this time?
Yeah, I would say just being able to quantify the savings on their end, paint that picture, use our data in conjunction with their data to say, okay, these are the patients. This was where we started, right? This was baseline. And these were the goals that we identified early on in the program, and then utilize our data in conjunction with their claims data if we're talking about payers or expenses when we're talking about ACOs or whatnot, just to see how much were we able to reduce the overall spend on managing a specific population, but also when we look at the clinical side of it, how did the patient benefit from the program from a clinical perspective? What is their A1C? Are they filling their prescriptions and utilizing their prescriptions? We had one program that was a sickle cell program, and the entire purpose of the program was to do nothing but to get the sickle cell patients that were enrolled to work with their physician to start taking hydroxyurea. That was it. How many people are taking hydroxyurea? And that was the measure of success for that program. But yeah, I would say it's just the ability to clearly illustrate to our partners what their savings is, and also how did the patients benefit from it from a clinical perspective, and not just a clinical perspective, but also a quality of life, because those two go hand in hand, right? If you can get a person more compliant with managing their health, their entire quality of life changes. And that's really the cool part about sitting back and seeing the results of these programs. It's great that we're saving money and we're making money and all that kind of good stuff, but we're all in this for the healthcare part of it. We're in this for the patient, right? And to be able to see a patient's quality of life change is really the rewarding part of the whole process.
Thank you. Chief Miller?
I'm going to take a different approach on this conversation. I think this is a very dangerous conversation to have. If you're looking from a fire perspective, when we're talking about saving a health system or an insurer payer source money in a fee-for-service world, that is not saving money. We may be costing money that they would regularly bill for. So I would guard against having those conversations early on, and allow subject matter experts in those specific fields to lead those conversations. What I found is safer for us is anecdotal stories and successes that we've championed, that there's been a return on investment, that we've shown a success and a win. So I do sit on multiple boards and committees, whether it's, I work with an advisory board for Indiana Medicaid. We've worked with commercial payer sources, health system CEOs, and then private practitioners that work on, we want to show benefit in each one of those areas, whether we're talking about retention of primary care physicians and recruitment, how we can incentivize them with increased RVUs and that workspace. But I've got down that rabbit hole with the CFO and lost horribly when having conversations with shared savings, and led me to get a lot more education and find out how much I really didn't know. Luckily, I have a fantastic group of nurses and presidents at the hospital that have mentored me for many years to make sure I'm very careful in my conversations and wording. And then I punt to subject matter experts to hold those conversations. Because ultimately, for me in a fire department, reimbursement looks much different than it does in private EMS. Funding and sustaining private EMS is a lot harder than it is in a fire department. We are subsidized through taxes, and it's a community benefit. And if there's a need, whether it's 911, community paramedicine, fire protection, that community dictates what their level of service is going to be. So the business model is different, and my partners' relationships may look different. So just be careful early on in those conversations, but be a part of that team and engaged in how we're optimizing that to where we're each receiving a return on investment, no matter what that looks like.
I think what I heard too is tailoring your talking points, your information, your data to the audience you're meeting with as well. Absolutely. Too. Because if it's an insurer, they're going to want to save money and improve care,
but they have that data.
Right. They have that data, providers, that you're right, it's their revenue stream, and you're talking about taking away some of those, but you're helping with coordination of care. Maybe it's increasing revenue in other areas that may not be as well too. So you're absolutely right. I think it's taking and stories impact, are so important, and being able to communicate and share that to the community and to all are important. This
is where I struggle with Zooms, because it's very hard to know my audience.
Right. Yes.
typically when I'm invited in, I already know who I'm speaking to, and then I tailor each one of our presentations based on our audience.
Well, it's a valid other point of it too. And I'm glad that we have both experiences here to share that, because you're both absolutely right.
Yeah, and they look like Chief Miller said, just telling success stories. Because if you tell a success story in like a case study, okay, then your audience is going to connect the dots for themselves. They know the downstream effects of that particular success, right? So oftentimes you don't even need to say anything. They connect the dots themselves.
That's a great point. So as organizations that have worked with the center or currently working with us, we're all about evaluation. But, the center is partnering with an evaluation organization to help with this area of the community paramedicine program. And so areas that we're looking at are, assessing the community paramedicine model to see the impact and outcomes of that target population to the stated goal. It can provide opportunities to make sure reimbursement opportunities are maximized, ensure ongoing stakeholder communications and engagement with this work. I think those points were represented in the panelist discussion just previously, because it will inform, it will provide that information for ongoing engagement and impact. And, and as part of your evaluation too, it will also inform what areas of your program may need tweaks or that are extremely successful and you want to build upon those. And again, these are just examples of some of the areas that will be assisting and helping think through. And so you both have talked about this, throughout our time together this morning. But what other aspects of your program do you evaluate or measure? What are they and how have you used those results? So we've talked about, the funding, the payers, telling the story, but what other things are you looking at and evaluating? And Paul, we can start with you.
So each one of them is a little bit different. Internally, we're looking at touches and stuff like that. How many, making sure time utilization is well spent when we're managing our resources. But any kind of research is very expensive, obviously. So that's where we utilize the universities, whether it's Purdue University or University of Indiana. We've used Wabash College. Each one of those, whether we're looking at undergrads, master's level, doctoral level, and maximizing their resources. A lot of people need practicums. I use what's important to them. So we'll typically go and speak with the universities, and like Purdue University, I'll go speak to 30 people entering their master's program looking for master's research projects. We will talk about our project, and the ones that align with them, we'll work with a lead professor and then develop stuff with our health system that's going to have a return on investment. So we tailor different projects based on how many practicum hours they have, what resources the undergrads can give us to do the legwork, maybe qualitative, it may be whatever. And then just use that for different touch points when I go out and speak with the State Department of Health, maybe Indiana Medicaid, that will use that research differently. But internally, I am not doing a lot. I would mix it up. And there wouldn't be, a lot of trust in the research I'm going to do compared to a university. So credibility is everything. And if I have a misstep, that failure is going to live with me forever. Those large universities don't have the misses. At least not the professors I've worked with.
Those are great ideas. Thank you. Richard?
Yeah, some of the two things come to mind. One is, if you look at the triple aim, one of the parts of the triple aim is improving the experience of the community, right? The patient's experience. So, we spend a lot of time and effort to get meaningful survey results back from the patients that we're working with, because that's important to us. What did you like about, when the medic came and visited you? What didn't you like? That kind of stuff. What could we have offered that would have made your experience better with this? So we spend a lot of time and effort, like I said, to get that meaningful data from the patients. And then we in turn use that as part of our QI initiatives internally. But also we share that data with our partners. You know, if we're talking about a payer, you know, they want to know what their members' experience was with this program, you know, because they're paying for it. You know, same thing with the provider. They want to know that their patients are happy with the program that we're providing to them. And the other part of that too is, and Chief Miller kind of talked about this, is appropriate utilization of our resources, right? Not every community paramedicine call requires advanced level care. A lot of them require just basic life support, just somebody to go into the home, do a social determinants of health assessment, do an environmental assessment, check some basic life vital signs, launch a virtual visit between the patient and their provider, right? Low level when it comes to clinical care, right? But how do you staff your program to be able to control your costs and use the right resource for the right particular mission? Okay, so we're actually in the process of installing a software that uses a lot of AI to basically identify what resource is most appropriate for a specific job that needs to be done. And especially this is really important when you're talking about rural communities because of the geography. You know, you might have, you know, a 35 or a 45-minute commute from patient 1 to patient 2. And then another, you know, so when your patients are spread out over a large geographic area, you know, proper utilization of your resources to make sure that you're operating as efficiently as you can is really important to controlling what your costs are and ultimately the level of service that, you know, you're providing to the community.
Thank you. And, you know, we've done a lot of talking here, myself and our panelists today. And so I want to open up real quick. I'm taking a note of our time. We have about 9 minutes left of our time. And I know folks are anxious to hear about how they could learn more about this opportunity with the Delta program. But I want to take a moment and pause. And in regards to the framework components, what questions do you have? You can use the chat box. You can come off mute and speak up too. But what are there any questions that are burning at the top of your mind right now? Okay. I think Karen, in the absence of, you know, if things pop up in the chat box, we can come back to them or folks think about it and come back. But I'll turn it over to Karen now to kind of talk about what our next steps of this technical assistance opportunity are. Karen?
Thank you. So you've heard a lot about our program today, and hopefully you've got some interest and excitement, even amongst yourself or community partners, for our healthcare organizations that are interested in applying for this technical assistance opportunity. We are going to be utilizing our existing implementation and technical assistance process. And you can see the link here on the slide, and the slide set will also be sent out. When you utilize that form, you will select the type field and select community paramedicine there. That will notify our team that you are interested, and we will follow up contacting each location that applies to set up an application review call. And then all the organization call notes will be aggregated for recommendation for this technical assistance opportunity. All of our past and current healthcare organizations, a part of the Delta Region Community Health System Development Program, are eligible to apply and participate, but priority will be given to organizations that are currently or were successfully graduated in good standing across all of our program areas to qualify for this technical assistance. The application will open today and it will close March 31st of this year. The project length will be variable for implementation, just like our other program areas, because we know that collaboration takes time and we want to adjust to the needs of each of the organizations community partners, and those key stakeholders. That being said, we will also use a staggered approach as we work with these selected organizations and communities. We have funding to work with up to 4 locations, so we encourage you to apply today. Also, if you have any questions as you're thinking through whether or not to apply, this is my contact information. So please feel free to outreach and ask us any questions. Alyssa, I have made it through. Do we have any additional questions in the chat?
None that have come through. So thinking about that, participants, we have about 45 folks on the call here too. Are there any questions that came to mind, whether it's for our panelists here, the TA program, the application process, and so forth? Are there any questions we can help with right now? All right, Karen, I think, at this point in time, we've provided a lot of information to think about. We have our contact information out there, and we'll be following up with an email to all of our organizations too with these slides and information and how to contact, because we know it takes time. Questions might not happen right now to reflect on and bring them forward. So we are open. There's not a wrong door to enter and ask questions about this.
And thank you, Richard and Paul, for joining us. I know our listeners have appreciated your perspective, and we have as well.
Yes, I was writing down things I was learning along the way as well too, and to make sure to bring forward. So thank you so much.
Absolutely. Thank you for the opportunity.
Yeah, thanks for having us.
Enjoy the rest of your day.
Take care.
Thank you, everyone.
Bye.
Bye-bye.